Chapter 35, Key Pediatric Nursing Interventions. We're going to talk about the 8 rights of pediatric medication administration. We're going to talk about some of the differences in the pharmacodynamics and pharmacokinetic properties. We're going to talk about some medication doses. We're going to talk about how to give medications. We're going to integrate some of the atraumatic care. We learned a little bit about that in one of the other chapters. We're going to talk about some IV medications and then nursing management for infusions. So your rights of medications. So we all know about your right medication, time, patient, route, dose, documentation, right to be educated, and right to refuse. Does a kid have a right to refuse medications? You know, that's a hard one because the parents still have that parental control. So we do talk a little bit about that. The right to refuse is sort of one of those newer things that we see. But parents do have a right to refuse. Kids, not so much. So your pharmacodynamics is that behavior, that medication at a cellular level, and it's going to be affected by the immaturity of some of the systems in the infants. When we think about pharmacodynamics, we're thinking about, you know, their liver isn't as mature. They, we talk a little bit about some of the interactions. If some medications need to be taken on an empty stomach, an infant's stomach is most often full because they eat so often. If it needs to be taken on a full stomach, so timing those things. Your pharmacokinetics also is that absorption, distribution, excretion, and that is also affected by the child's body weight, their surface, and their body composition. So with oral medications, children have slower gastric emptying, so they have some increased mobility. If you know an infant, as soon as they eat, they're pooping already. They have a larger small intestine, proportionately higher pH, so that can affect certain medications, and then some decreased lipase and amylase secretions. Intermuscular, so their amount of muscle mass is smaller. Their muscle tone and perfusion is smaller. We always use the vastus lateralis when we're giving medications, but never use a deltoid in small children. They don't have a good deltoid muscle, but the vastus lateralis is a good muscle. Sub-Q, sometimes that there's decreased perfusion, so that absorption is limited. And then the topical, there's a greater body surface area, and so greater permeability. So sometimes those act very fast, the topical absorption medications. So factors that affect the distribution would be that higher percentage of body water in infants, that fluid change, that extracellular fluid exchange is faster. They have decreased body fat. One of the biggest ones is the liver immaturity, and so altering that first pass elimination. So drugs that are do like a first pass through the liver, they miss that. So sometimes there's more of effective drugs. So that's what we kind of worry about certain drugs. They have an immature blood-brain barrier, so especially neonates, so certain medications can cross that barrier. When we talk about medications, we talk a little bit about when we explain it, why it's needed. We want to talk about what they'll experience, what's expected of them, and then how the parents can participate. Can a parent give the medications? If I take some Tylenol in to an infant, I may ask, or a toddler, the parent, if they would take it better from them or me, and sometimes they will. I don't leave the room. I watch how they administer it. I can't just give it to the parent and walk out, but I can let them give it, and I can supervise it, and I could chart it. I would never let a parent obviously give a sub-Q or an IM injection, but Sometimes the medication they'll take better from the parent. Sometimes the parent will say, no, they don't take good medicine very good, so you give it to them. So how do we determine it? We want to get the body weight. We always do it in kilograms. So we always convert it. We're going to check for safe ranges, and then calculate the low safe range, a high safe dose, and then is that in between it. So you may do that in some of your med calculation questions on your exams also. When we give liquid medications, we want to use a syringe, some kind of a medication spoon, a cup. You want to, when using the dropper, you want to obviously have it without a needle. You know, somebody did it once, so that's why that's in there. Sometimes you want to put it in the side of the mouth, give it slowly and allow the child to swallow. You never want to just go and squirt the whole thing in because that whole thing will come back up. If it comes back up, how do we know if they absorbed any of it? How do we know what they got? Do we repeat the dose? Obviously, that's a discussion you'll have with a physician. But sometimes what I've had some luck with is kind of wedging the syringe if they have teeth in between the teeth, because if they can bite down, they can spit it out. So you want to make sure that they're getting it. But then, like I said, just a little bit at a time and let them absorb it. They may cry, and then all of a sudden they'll swallow it. Sub-Q, so it goes into the fatty liver, and I thought this was a really good picture of IM, sub-Q, IV, intradermal, kind of an explanation, and then you also can see the angle. So we did intravenous practice and skills, so we need a lesser angle for kids. Intradermal, what we give there is it's the J-tip, so it's a pain medication for kids when we start the IV. So atraumatic care, we talked a little bit about this in the other chapter. Comfort holds, really important that we can integrate the parent in those comfort holds if you have a parent who will participate. There's some topical anesthetic products that are on the market that we have available. They take long to work, maybe an hour, and sometimes you don't have an hour before you start an IV. It only would numb the skin. It doesn't go any further than the skin. Educating the parents, so the more they know, the better they can understand what you're doing. We want to make sure we're double checking all medications. Most hospitals have a policy to double check all pediatric medications. Encourage the parents to participate with the comfort holds. And then you want to really have good holders when you're going to give an IM injection, because if they move, that can cause a big problem. Sometimes we have to give 2 injections because of the quantity of the medication, the volume, and so we'll break it up into 2 syringes, and typically 2 nurses will go in at the same time, and one will give it in one leg and one in the other at the same time, and then you're done with it. Once you get 1 injection, and it's really hard to go back in and have the patient even somewhat cooperate for that second one. So you do 2 at once, still hurts, but you're done, and have your Band-Aid ready. So peripheral IVs, we talked a little bit about those, is to make sure that we have the rate that the doctor wants, that the dilution is correct. We don't typically do many central infusions. You work in ICU, you may do some central IVs, but we do peripheral IVs. So central line is usually inserted by a physician. It's under the skin, a large vein, and they usually are reserved for your ICU patients. Factors that affect it is what are we giving? So are we giving something with potassium in it? Potassium is very caustic to the vein as far as pain goes. So if we're giving that, we may want to do a larger vein. How long are they going to have it? Typically in the ER, we stick an IV in the kid's hand. They're good to go. Their hands are a good choice. The age and developmental level. if I have a teenager, I can put it in their AC and let them know you can't be bending your elbow. But I can't do that with the smaller kids because they aren't going to know enough to keep that arm straight. And then the condition of their veins. Kids with chronic illnesses have very bad veins, in my experience. Sometimes parents will tell you that this is a really good vein right here, this is a good vein, and I believe them because they know. Their kids sometimes have been picked and picked and picked. If I don't see anything, I'm going to see if someone else can see anything. If not, I'm going to call for an ultrasound-guided IV because that's going to be the best bet for these kids. I'm not going to just pick them just so I can get the IV. So get your equipment before you go. The hand rather than the wrist or upper arm. This is a J-tip. It's hard to see. When you're in skills, we'll kind of go over what the J-tip is. It is intradermal. It's buffered lidocaine, and there's a CO2 cartridge on the end, and that pushes the medication under the skin without a needle. Those work really, really good. This is a little wee site. You put it under the hand, so you kind of put the little kid's hand around it, and then it'll illuminate veins from below up through. That only works for small children. This is a vein finder. This is unbelievable. You can find a vein anywhere. You just hold it over, turn it on, and you can see all these veins here. There is a stand for it, so you can have it sitting there while you're starting your IV. A lot of times we do need to use vein finders. Some of the rules or policies would be make 2 attempts to gain access, 2 times, 2 tries, or 2 times 2 minutes if it's an emergency situation. But you really want to make sure that you're not picking and picking and picking and picking. Unless you're the last person, you can't pick more than twice. Again, your comfort holds with the parents. Coordinate with other departments. So if they're going to be going to do surgery, you want to make sure, are they going to get their IV when they're in surgery? Because sometimes they will give them anesthesia through a gas mask, and then they'll put the IV in when they're in surgery which is usually easier. And so I always want to find that out before I start the IV and traumatize the kid. If they're going to put it in when they're asleep, that's great. I just need to know that. Secure it, so minimal amount of tape, but secure it. So this is a head IV. They put a rubber band around the head and then go into the veins towards the heart. This is a part of a medicine cup that they have put on to secure it. We don't do a lot of head IVs anymore because we have the use of ultrasound-guided IVs. There's nurses that are trained in that. And those are, you can put in a deeper IV and a longer IV so that it is more secure. These head veins are okay. The kid can't have any hair, and they really freaks the parent out. So I prefer to go with the ultrasound-guided IVs. So IV formulas that you need to know. Your doctor will typically order the IV formula, but this is kind of what they go by, this formula. So you get 100 mils per kg of body weight for the first 10 kgs, and then you start adding. For the next 10, up to the next 10 kgs, you add 50 more, and over that, 20 mil per kg of body weight for the remainder of the body weight. So we'll do some of these practice either Wednesday or Thursday in class, so we can practice the IV formula for kids. IV management, so you don't need to remember urine output, but you do want to see urine output if you are putting an IV and treating dehydration. You want to avoid infiltration, so this is a bad infiltration, so always check your IV sites frequently. We're using short, very tiny IV catheters. We use a 24 gauge, and so they can become loose and they can become infiltrated. So you really want to make sure that you are watching that carefully. Just continue it using atraumatic care, so explaining what you're doing, and assuring them there's no more needle picks, things like that. These are just some IV tips and tricks, and then different sizes that you would use. Okay.